Before we dive into the specifics of TNM classification, it is important to understand why staging is essential in cancer care because it tells us how far a tumor has spread, helping to guide prognosis and for treatment decisions. The idea of stage comes from observation that the patient with localized disease survive better than those with more advanced spread. A cancer stage at diagnosis reflects tumor growth and its spread and its interaction with the host. The TNM system standardizes this description, ensuring clear communication and consistent treatment planning across the patients and institutions. The TNM system describes the anatomical extent of malignancy by assessing three key components: T for the extent of the tumor, primary tumor, the size and the extent, both of them; N for the presence or absence and the extent of the regional lymph node metastasis; M for absence or presence, extent and the site of the distant metastasis. Arabic numerals such as T1 to T4, N0 to N3 and M0 or M1 indicate increasing levels of involvement. In essence, TNM functions as a shorthand notion that communicates how far a cancer has progressed. There are several general rules that apply across all tumor sites. First, all cases should ideally be confirmed microscopically. Cases without such confirmation should be analyzed and reported separately. Each case receives two classifications, a clinical and pathological. Clinical classification is based on the information gathered before treatment through examination, imaging, endoscopy, biopsy, or exploratory procedures. And pathological classification, which incorporates surgical and histopathological findings. The pathological T category must be supported by adequate resection or biopsy, and if more than one surgery is performed, the final pathological TNM classification must reflect all specimens. Second, the pathological assessment requires examining at least one lymph node along with primary tumor, except in cases of unknown primary. A biopsy confirming the highest N category can be used for pathological node N category, but lymph node excision alone without evaluating the primary cannot establish a full pathological N category except when the primary is unknown. For distant metastasis, microscopic confirmation of the metastatic deposit is required. However, if the highest T, the highest N or M1 can be confirmed microscopically even without removing the primary tumor, then pathological staging criteria are met. Third, once the clinical and pathological TNM have been assigned, they can be grouped into Roman numerical stages 1 to 4. Once recorded, stage must remain unchanged in the medical record. For surveillance and the clinical and pathological data may be combined if either is incomplete, and the method used should be documented. Coming to the fourth, if there is uncertainty between the two possible TNM categories, we choose the lower or less advanced category. The physician may still treat as if the disease were at a higher stage, but the staging rule remains. This does not apply when the information is missing. In those cases, TX or NX should be used. The next, in cases of multiple tumors in the same organ with the same histology, we classify tumor with the highest T category and note multiplicity in brackets, such as T2 within the brackets. M stands for multiple. For paired organs with multiple or bilateral primaries, suppose for each tumor is staged separately, except when bilaterality is already built into the T or M definitions, or in malignant melanoma where each anatomical skin site counts as a separate primary. Finally, the timing of TNM staging. The JCC recommends completing staging within 4 months of diagnosis. In rare cases where the metastases are confirmed later but believed to have been present at diagnosis, they may still be used for staging. Otherwise, staging should be finalized within that 4-month window and remain unchanged thereafter. Let's see what's sentinel lymph node. Sentinel lymph node is the first lymph node that receives lymphatic drainage from the primary tumor. If it contains a metastatic tumor, this indicates that Other lymph nodes may contain tumor. If if the sentinel node does not contain metastatic node, a tumor, other lymph nodes are less likely to contain a tumor. Occasionally, there can be more than one sentinel lymph node.